Okay. Okay. So today would be a little bit of a different, theme and style, but I hope, it's good to change things once in a while. Okay, so we did have a break for 2 weeks, I think. Yeah, I think people needed a break. I was a little bit busy and so forth. Okay, so this is our number 6, okay? Okay, so case, 14 years old with hypertrophic cardiomyopathy, who just had an Holter like last 2 weeks ago, okay, May 31st, okay? And this is the Holter report by the technician. So there were some PVCs and runs of white complex tachycardia and with a maximum heart rate of 132, okay? He did not have symptoms at the time, but this is the technician report, and obviously it got me worried because he's hypertrophic. He's a patient with hypertrophic cardiomyopathy. So to begin with, any takers, like this is the rhythm strip, this is the maximum heart rate, and these are another non-sustained white complex strip here. So any takers, like do you do you agree? And anything else you want to say, or you're happy with the report? So this is meant to be interactive. So please, anyone, just anyone, unmute yourself and speak up, so that we move. Especially, we have Nasser there and the guys from Saudi Arabia. Please, unmute yourself and speak up, okay? Or anyone else?
Yes.
Yes. Who's this?
I can see the cardiac, Muhammad.
Yes, Muhammad. Yes. Go ahead. Sorry.
White complex subs.
So I apologize for the quality. It was sent to me by the mother. So it's not super. The quality is not super good, but I think it's sufficient. Okay, so you agree, Mohammed? There's white complex tachycardia?
Yes.
Yeah.
Okay.
So you sign it was ready to
With a short PR probably, yeah.
Anyone else want to disagree, or everyone agrees? And I will comment later, but I just want to give everyone a chance to interpret this rhythm strip. And if anyone has any disagreement, just speak up. Otherwise, I'll proceed. Yes. Okay, I'll proceed. Anyone want to say something else?
I just want to mention, Dr. Muhammad, that there is a P wave before the white complex QRS.
Okay, so what, Yani? What are you trying to say?
I don't think that this is a ventricular ectopic.
Okay, so what do you think then?
I think it's an interventricular delay.
Okay.
More than a ventricular ectopic.
Okay, so you think it's interventricular conduction delay. Okay, fair enough, fair enough. Okay, anyone else?
Probably it's a too short a PR. Maybe this is not produced by this P wave. This maybe atrial ventricular rate is almost same.
Let's see. Okay, so
isorhythmic VT.
So Dr. Babu,
maybe runs of apparent conduction BECs.
Okay, or aberrant. So I heard, VT with with similar rate to the sinus, rhythm. I heard intraventricular conduction delay, sinus with intraventricular conduction delay. I heard atrial rhythm with aberrancy, or sinus rhythm with aberrancy, right? Anyone else? Okay. Okay, I'll proceed so that we don't, we don't waste so much time. Okay, so I'll come back to it, okay? Okay, so this is his echo. He, again, he has hypertroph, and it's concentric severe LVH on echo. The maximum diameter was 27 millimeters on the intraventricular septum, okay? His MRI, I usually like to do MRIs for such patients, and there is indeed septal thickening with maximum of 30 millimeter at the mid-septal wall. Again, I apologize for the quality. This is all per, mom, text, messages, okay? And there is also thinning of the distal apex, and also there is late gadolinium enhancement, suggesting scar on the, you know, many areas of the LV, mainly basal.
Fibrosis.
Right, fibrosis, okay? And there's a little bit of left atrium enlargement, and the function, there's no LVOT obstruction, but the function is 56. So it's probably minimally depressed because, like, you know, with hypertrophic cardiomyopathy, usually they have, you know, they are very, the function is usually super good because it's a diastolic dysfunction. So 56, you know, you may call it normal or a little bit below normal for him. But anyway, so that's his MRI report. Okay, fair enough. Okay, and of note, he is on low dose of atenolol for, you know, reasons that I will say later. Okay, so now you have this patient who is 14 years old, hypertrophy. You saw his Holter, you saw his echo, you saw his MRI, and he's in your clinic and he's already on beta blockers. What do you want to do next for him? You know, he's a typical, you know, cardiology patient, you know.
No symptoms, huh? No symptoms.
No symptoms. No syncope, no palpitations. So what's next? You know, any just follow up in 6 months, or do you want to do something else? Anyone?
He
I
has.
think just
I'm sorry?
Okay, carry on.
I think just follow up will be sufficient in this point.
Okay.
I remember this patient because I'm the one who did the echo.
Oh, really? Okay. There was no name. Did you see a name?
No, my name was.
Oh, okay. 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 I hope there was no name.
London signature is there.
But not the patient name, right? Okay. Anyways, anyone else want to say something? Or so there's a big question mark that we should address. What is it usually with hypertrophy? What's
Maybe sudden death.
Right.
So this is hypertrophic cardiomyopathy, which is and the tenor mean it looks controlled with no BVCs or symptoms, but I think these BVCs appeared while the child was in severe bradycardia because of tenormin. This is what I think.
Okay.
So I think next we have to think of ICD because he is not tolerating this high dose of tenormin.
Okay. Yeah. So the question mark, the big question mark is, does he need an ICD? So that's, for hypertroph, obviously they are at risk of sudden death, and usually EP question, a cardiology question to the EP personnel is when does he need an ICD? Okay. Okay. So in order to answer this question, of course we have to review the data. Okay. So the again, the main concern with hypertrophic cardiomyopathy is heart failure plus sudden cardiac death, right? So my job is to worry about the sudden cardiac death risk, right? So of course the ICD is the only means or measure to prevent sudden cardiac death in hypertrophic cardiomyopathy patients, meaning beta blockers or any other drugs had not been shown to prevent sudden cardiac death. Okay, at least in the usual doses. Maybe in super high doses, maybe, but people often don't tolerate super high doses. Okay, so in general, medications for hypertrophy do not prevent sudden cardiac death. They may prevent symptoms, but not sudden cardiac death per se. Okay, so ICD is your only option to, if you're worried about sudden cardiac death in a specific patient, ICD is your only option, right? So, however, in pediatrics, the ICD is high risk. There are way more complications in ICD in pediatrics compared to adults because of growth and other factors that I would also mention. When someone with hypertrophy had sudden cardiac arrest in the field and got resuscitated and is admitted, this is no brainer. This is slam dunk. He needs an ICD. I don't care what his age, what his any risk factors, what his history. If he had a sudden cardiac arrest and got survived this sudden cardiac arrest, he needs an ICD. If someone has sustained VTE, he needs an ICD. Otherwise, besides sustained VTE or cardiac arrest, then you have to determine which patient needs an ICD. So this patient, he never had cardiac arrest and he never had sustained VTE, and the Holter that the Holter that I just showed wasn't sustained VT, and I will say why later, okay? So this patient did not have sustained VT, did not have cardiac arrest. So the question is whether he needs an ICD. So now, there's secondary prevention ICD, again, when you have sudden cardiac death or VT, and there's primary prevention ICD. These are more complex. For hypertroph, it's difficult to know which patient deserves an ICD for primary prevention, and because the data is a little bit limited, and I'll show you the data in a second now. So this is the most recent paper. It's a multi-center or international multi-center study. It's just published exactly last year, about risk factors for arrhythmic events, or lethal, or fatal arrhythmic events in children with hypertrophic cardiomyopathy. And it did show that LV posterior wall thickness, with multivariate analysis, meaning independent risk factors, the LV posterior wall thickness and LV outflow gradient of less than 30, meaning if you have non-obstructive hypertrophic cardiomyopathy and you have an LV posterior wall thickness Z-score of more than 5, these were the only risk factors that determines that the patient is at risk for sudden death, right? So and FYI, it's a big study for pediatrics. It involved 446 children, and with a mean age of 10 plus minus 5.7 years. Okay, so this study only showed that LV non-obstructive hypertrophic cardiomyopathy, which is strange, meaning if you are obstructive, it's protective, and LV posterior wall thickness of Z-score are the only risk factors. And this is in adults. The story is a little bit different, and I'll mention the adults data in a little bit. So this is pediatrics, pure pediatric data, and the blue line is in those patients with an ICD for primary prevention, meaning the cardiologist implanted an ICD for primary prevention, for prophylaxis, because he was worried about him, not because he had VT or he had sustained VT or he had cardiac arrest. And you can see here that the blue line, that the arrhythmia, freedom from arrhythmia compared to those who had sudden cardiac arrest or sustained VT is way less, is way more. So, patient who had primary prevention ICD, they required their ICD way less than patients who had ICD for the VT and sustained cardiac arrest patients. So this tells you that we are a little bit aggressive in implanting ICD, and the median time to an intervention from the ICD was almost 3 years, meaning you implant an ICD, it takes 3 years for the patient to need the ICD on average, okay? So meaning we're implanting an ICD a little bit earlier than what we would like. And then again, remember, the more ICD is in, the more the risk of complications. So we have to be better at knowing which patients deserves an ICD, okay? And this is a more, this is a similar paper, multi-center, less patients, but it's back in 2013, with a little bit, more mean age of 14 compared to 10. The appropriate shocks were only 19%, meaning many patients had inappropriate shock. Meaning inappropriate shock, meaning the device defibrillated the patient because of sinus tachycardia, because of SVT, or because of artifact, the device thought that it was VT, so again, inappropriate, right? So this is not good. This is very painful to the patient, and of course has psychological and consequences to the patient, and also impacts generator life, meaning because whenever the generator defibrillates the patient, the time it has to keep functioning decreases, right? And then obviously there were like 4% death, and the complication rate was 41% over the study period, with an inappropriate shocks of around 30%. So again, many complications, many inappropriate shock rates, with an average time for needing the therapy from the device around 2.7 to 3 years. Okay, so not so good, right? So so many complications, so many inappropriate shocks, minimal appropriate shocks, and so forth. In this paper, they said that the primary prevention risk factors associated with appropriate shock, meaning patient who had the primary prevention or secondary prevention ICD and actually needed the ICD. Main risk factors were when this patient has massive LVH, or there's unexplained syncope, family history of sudden cardiac death, and then less so non-sustained VT and hypotension in response to exercise. So massive LVH was a big factor, similar to the most recent study, but syncope, family history, are, at least in this, please mute yourself if you can. So syncope history was also risk factors here, but not in the most recent, multi-center study. So again, a little bit confusing. And older studies did show similar, less number of patients, but basically similar results. High risk of complications. Average time to needing a shock was, here 2 years. Inappropriate versus appropriate shocks. Little appropriate shock and high inappropriate shocks. And in this paper, family history was important in terms of needing an ICD, and history of obviously history of resuscitated arrest or unexplained syncope was also important. Okay. Another paper, this is only 22 patients, so less powerful paper, but again same thing. Median time to needing a shock was 3 years, and couple of inappropriate shocks and couple of complications. There was no risk factor analysis because of low number of patients. Another paper, there was no risk factors associated with adverse events in this paper. So again, they did not, statistically, there was no risk factor that stood out to be, predictive of sudden death in this cohort. Okay, and another paper, again, same thing. There was no risk factors on multivariate analysis to predict sudden death. So they did not know. So finally, there's also a meta-analysis that was done 3 years ago that that included 25 papers and 3,394 patients, and concluded that if you had a previous lethal cardiac event, if you had non-sustained VT, if you had syncope, if you had extreme LVH, and this also adverse cardiac event included the sustained VT, it was, these are the main 4 risk factors for determining whether this patient needs an ICD. So in other words, if you have sustained VT, if you have history of cardiac arrest, if you have non-sustained VT and you have syncope and LVH, these are your risk factors, which is very similar to the adults. Well, this study is very similar to the adults. The adults also say the same thing, but did not, the family history, the whether it's obstructive or non-obstructive, and other risk factors were not found to be significant with this meta-analysis. So long story short, long story short that
لا ما تخلي علي حبيبتي حياتي.
Adnan. Okay, so I think Adnan muted himself. So long story short, there is limited data to know which patient really needs an ICD when it comes to primary prevention. Okay, so we need more data. We need more multi-center, studies to know exactly which patient deserves an ICD for primary prevention reasons. Okay, versus the adults, they do have obviously more patients and they do have established risk factors that everyone knows, like family history, genetics, and non-sustained VT and syncope and LVH and stuff. And this paper suggested that the more scarring you have on MRI, the more risk of sudden death. This is an adult paper. We don't have pediatric paper showing the exact same thing yet, because MRI is new in terms of assessing scars and stuff in pediatrics. So just FYI.
Maybe they may take time to develop scar.
Right. Plus, people don't do MRI routinely for hypertrophy, except recently. Yeah. Okay. So just FYI, ICD lead failure is very high in pediatrics, and the young, so this line the brownish line is less than 8 years of age. So the younger you are, the less likely the ICD would survive on the patient, meaning that, you need to replace the leads and, add more leads and so forth. So the younger you are, the more likely that you will have issues with ICD leads, okay? And same thing for pacemakers, by the way. And in terms of sudden cardiac death and hypertrophy, usually there are two, in pediatric age group, usually they are very, they may die when they are, infants or in teenager years. And they are usually, between 2 and 12 years of age, they are usually fine in terms of sudden cardiac death risk, okay? So again, young teenagers and, infants are at high risk, but in between they are okay in terms of risk for sudden cardiac death. So this is where you need to think of ICD more when they are at the, those two peaks in terms of age in pediatrics, okay? Okay, so in summary, when you have again cardiac arrest, survival of a cardiac arrest patient and sustained VT, that's slam dunk. Everyone would implant an ICD for such patients. However, when you have other risk factors, then people, wonder whether you need an ICD or not, especially for pediatrics. So that because of the high rate of inappropriate shocks, high rate of complications, low rate of appropriate shocks, and so forth, okay? And, MRI data is coming up, and genetic data is coming up, and ECG abnormality data is coming up. So we still need more information. So back to this patient. Any questions so far in terms of data for ICD and hypertrophy in pediatrics? Any questions so far?
Mohammed, you didn't tell us the diagnosis of this ECG.
Well, yeah, I'm coming to it now, okay?
Oh, okay.
Okay, so back to this patient. He's 14 years old, he's definite hypertrophy, and there is no family history, genetic test is pending, and I exercise test him, and nothing happened in exercise in terms of ST segment changes or VT or AFib or SVT or anything. And so back to this Holter. So I agree with Nasser. So you have to pay attention, like you see my mouse, right?
Yeah.
Yes. So there's PQRS, and then P with sudden shortening of the PR interval and wide QRS, right? And then P super short PR, wide QRS, right? And then the same thing here. So this is the P super short PR and wide QRS. P super short PR and wide QRS. So what is super short PR and wide QRS preceded by a sinus P? What is this called?
Bundle branch block.
No.
Pre-excitation.
Pre-excitation, right? So this patient has WPW, but it's intermittent. So that's what's confusing about him. He has intermittent WPW, meaning it comes and goes, okay? So here, he had no WPW, and then suddenly the accessory pathway conducted antegrade, meaning from the atria to the ventricle, resulting in short PR and wide QRS, okay, as expected, right? Mm-hmm. But this patient has intermittent WPW. It's not VT, it's not idioventricular or accelerated ventricular rhythm with similar sinus rate. It's not PVCs, it's not aberrant conduction. It's it's just a conduction across the accessory pathway. Make sense? So this is this is why I picked this case, because first of all, it was misread by by people that this is VT or slow VT, and WPW could be intermittent that people do not recognize. Okay, so just know there's something called intermittent WPW. So that's indeed intermittent WPW, and it's this patient. If you look at his previous records, it's all over the he has intermittent WPW throughout. Okay, and at some point in his chart, people had said he had non-sustained VT. It's probably also intermittent WPW, because I did not see any evidence of non-sustained VT on all his ECGs. So it's probably also intermittent WPW that people misinterpreted as non-sustained VT. Okay, so that's confusing. That's why I mentioned this case to you guys. And just know that HCM and WPW is often there are many syndromes and diseases that has WPW and hypertrophic cardiomyopathy, and this is a list of specific examples. you know, this patient is genetics is unknown yet. So I don't know whether he has any of those. I doubt, but maybe. But, you know, HCM with WW is common, okay? And so you have to, you know, whenever you have HCM and the wide QRS and short PR, always wonder whether there is WW involved, okay? Okay?
Mhm.
Okay.
Now, one question.
Yes.
He has got left atrial enlargement. He has got WPW. So is he a candidate for atrial fibrillation and
Yeah, of course.
sudden cardiac death?
Yeah, so if he has, you know, if he has atrial enlargement, so then obviously he's at risk of AFib. And if he has WW with AFib, that's not good, right? The only, you know, I will speak about this. So I will, you know, I will speak about what does intermittent WW means compared to someone with, you know, with persistent WW. So there is a difference between intermittent WW and persistent WW in terms of risks for sudden death as well. So that's an important, you know, discrimination, and I'll tell, you know, I'll mention the data on this in a minute. But before I proceed, also, you know, to make things a little bit more confusing, sometimes with HCM and in general cardiomyopathies, not necessarily HCM, for example, dilated cardiomyopathy, you may have an ECG that looks like WPW, but it's not true WPW, meaning, you know, I will draw this. I mean, if this is too complex to you, that's fine, ignore this, but, you know, it is important to know, especially for cardiology. So meaning, if you have, okay, if this is your, you know, this is your heart, okay? So accessory pathways means that there is an accessory pathway across the AV valve, okay? So there's a pathway, you know, above the AV node that conducts the atrial activation into the ventricle, okay? That's your usual true WPW, okay? Meaning if you get AFib here, the AFib would get transmitted into your ventricle very fast because the AV node blocks your AFib conduction, tries to block it and does a good job. And usually if you are an AFib without WPW, you usually doesn't die suddenly. You don't die suddenly because your AV node only conduct, you know, let's say at 150 beats per minute, 160 beats per minute, 170 beats per minute. It doesn't conduct very fast because your AV node is smart enough not to conduct each and every AFib, you know, beat. But if you have an accessory pathway, you know, this is not the case. In accessory pathway, often they can conduct way more than the AV node, and then you're at risk of VFib, okay? However, sometimes you have an accessory pathways that are below your AV node, okay? For example, here, you know, in this case, the ECG would also show delta wave, okay? But the only difference would be that the PR would not be very short because, you know, because the sinus beat would come in through the AV node and then to the pathway, meaning there is some delay from the AV node and hence there is no short PR, and then you will see the delta wave. So sometimes you see this pattern on ECG in patient with hypertroph or DCM, dilated cardiomyopathy. So this tells you it's probably not your true accessory pathway that's above the AV node. Rather, it's an accessory pathway that is below your AV node, which is way more benign, okay? Which is benign. Makes sense? Should I repeat this or it makes sense?
Yeah.
No, I didn't get it, Mohammed.
Okay, okay. So I'll draw this again. Okay, so, you know, the worry about the accessory pathway is that it conducts, you know, it conducts the atrial tachycardia or AFib rapidly into the ventricle, right? And then you get VFib, okay? Okay.
Yeah.
Imagine you have an accessory pathway below the AV node, like from the right bundle to the apex of the RV, for example, okay?
Okay.
Because you may have, you know, you may have accessory pathways below your AV node. We don't worry about them so much because even AFib or atrial tachycardia, it has to still go down the AV node and then into the pathway, right? So you are protected from developing VF, you know, or rapid ventricular, you know, rates because you have to go down the AV node and then into the accessory pathway. Make sense, Dr. Babu?
Yeah.
Okay.
Yeah, understood.
Yeah. So these are called pseudo WPW, okay? And often they are often seen in patients with hypertroph and dilated cardiomyopathy and any cardiomyopathy. So the reason why I'm mentioning it, because this patient is hypertroph. So, you know, I wondered whether he has WW that is, you know, true, or he has WW that is pseudo, okay? And the fact that you know, that he has hypertroph, I was a little bit, you know, I wanted to differentiate, and I did something called an adenosine. Well, we can do something called an adenosine challenge test. Anyone heard of adenosine challenge test?
No.
No. Okay, it's very simple. So again, you know, you give adenosine to the patient, okay? And adenosine will block your AV node, right? Right? So what will happen to your ECG? The ECG will get wider, right? Because if you have a true accessory pathway, everything will go down your accessory pathway, right? So you will change your ECG from this, okay, from this to this, right? Because everything will go down the accessory pathway. You'll get super wide delta wave. Make sense?
Yeah.
Okay. However,
Yeah.
if you have an accessory pathway below your AV node, you will not see this, because when you block the AV node, nothing will go down and you will not see this. Make sense? Okay.
Yeah.
Okay. So if you see widening of your QRS, you're in adenosine, then this proves that it's an accessory pathway of the, you know, of above the AV node, okay, in the AV valve group, okay, okay.
Yeah.
Yeah.
Okay. And also, you know, there are other, you know, let's say the same patient developed junctional beat. You will, you know, if he has true, let's say this patient, you see the Holter, and he has, you know, one junctional beat. He had one junctional beat. Okay? If he has an accessory pathway here, and the junctional beat, of course, here, then you will lose the WPW, right? Because the junctional beat will start from here and goes down, right? So you will lose, you know, his typical ECG would be like this, and then you get the junctional beat, which is narrow, right? So this, if you see this in the Holter, then this also proves that the delta wave is from an accessory pathway that's above the AV node. Make sense? Or no?
Again, Mohammed?
Okay. Let's say this same patient, you know, on a Holter had a junctional beat, okay? And the junctional beat was very narrow, like normal beat. This tells you that the accessory pathway was in the AV groove rather than below the AV node, because the junctional beat will come here, and then if there's no accessory pathway, it will just go down straight and normal, right? It has nothing to do with the accessory pathway, right? You will lose your delta wave if you have a junctional beat in a patient with true WPW. Make sense?
If there's a junctional beat, and if it is lost, it means there's no accessory path.
Yes. So let me draw it again. So, for example, let me draw it.
Where are you drawing? I can't see your. Yeah.
Wait. Okay, just a second. Okay, I lost my pen. I don't know why. Okay, here. Okay, so imagine you have an accessory pathway here, right? Okay, and you have a junctional beat came from the AV node. The ECG will look normal because your junctional beat started from, you know, from below your accessory pathway. So then you will lose the WPW, right? So if you see this on a Holter, like this pattern on the Holter, you see my my circle here. If you see it on a Holter, then this tells you this is a true WPW. This patient with a true WPW, you know, he has an accessory pathway above the AV node. This is the accessory path that you worry about. Okay. Okay. You have, you know, these are signs that you need to pay attention. It's a little bit advanced. I get this. And if you are, you know, if you think this is a little bit confusing, you can skip this. But just know that there are occasionally ECGs that look like WPW, but in fact they are like pseudo WPW because of this. Okay, because of an accessory pathway that's below the AV node. Okay.
Yeah.
Okay.
Yes.
Okay. Okay. So then, you know, and then in order to confirm this, you can give adenosine challenge test and stuff. Okay. Okay, let's proceed. Okay, so this patient, I think, you know, he definitely have septal thickening of you know 3 centimeters, which is the adult cutoff for severe hypertrophic, severe septal thickening. And he's, almost an adult. He's 14 years old. So he definitely has one major risk factor. He has WW, but the WW is intermittent. So, and I'll say, so I'm less worried about this WW, but I'll say why in a minute. However, it's a concern, but less of a concern, but it's definitely a concern. His EF is okay. His LA is a little bit, dilated. He has no family history, genetic or pending. So he's borderline in terms of whether he needs an ICD or not. Probably, if you ask 10 different people, 5 would implant an ICD, 5 would wait a little bit. So he's one of those, right? But let's say we decided on ICD. Of course, we have two options. We have transvenous type ICDs and we have subcutaneous type ICDs, okay? So everyone heard of transvenous type ICD. We have also epicardial ICDs, of course, but he's not an infant. He's not, he's not baby. So this is not an option for him.
What is for babies you'll do?
Epicardial ICD, open.
Epicardial. Okay, epicardial. Okay.
So obviously that's for babies, small kids. In his case, he's he's 45 kilos, I believe. So he's good for transvenous or subcutaneous. This is called subcutaneous. This is called transvenous. Okay. So the question is, which one, what do you prefer, or what's the difference between subcutaneous ICD and transvenous ICD? Transvenous ICD advantage. Anyone knows what's the difference?
No.
I didn't see
Less risk of inappropriate shock in the transvenous.
I'm sorry? What did you say? Sorry? Say this again?
Less risk of inappropriate shock in the transvenous one.
No.
Maybe. I don't know whether there's specific data on hypertroph and inappropriate shock. So comparing subcutaneous ICD to transvenous ICD, there are concerns with subcutaneous ICD in terms of inappropriate shock, indeed, but we usually screen them for that before implanting it. So once you screen them, I don't think there would be a difference in terms of inappropriate shock for subcutaneous ICD compared to transvenous ICD, okay? Unless there's data that you're aware of. I don't think there's data that suggests this, but are you aware of any specific data for hypertroph?
No.
Okay. Anyways, anything else?
I didn't see this subcutaneous before.
Maybe
Yeah.
you have to use more voltage.
So the benefit of, the transvenous advantage is it allows for pacing. So when you have a transvenous pace ICD, you can pace the atria or pace the ventricle. You can put an atrial lead and the ventricular lead, and you pace, okay? Versus subcutaneous ICD, of course, you cannot pace because it will be very painful. It's like transcutaneous pacing on an ECG, machine. It's very painful, okay? So you can pace, but you can pace with transvenous, but you cannot pace with subcutaneous because it's very painful, okay? So that's one advantage for the transvenous. However, the disadvantage for transvenous, there is risk of endocarditis, there is risk of DVT or thrombus formation in the innominate and superior vena cava, and also intracardiac thrombus. And extracting it, meaning, yes, meaning if it's fractured, yes. Sorry, say this again.
A damage of the tricuspid valve.
Right, damage of the tricuspid valve, and endocarditis of the tricuspid valve or TR of the tricuspid valve, and rarely you may damage the tricuspid valve indeed. So definitely, and once let's say you implanted the lead, and then 10 years later it fractured, and you want to take it out, it's very difficult to take it out because it gets stuck to the walls of the veins. Okay, so it gets stuck here and here, and then you risk perforating the SVC and the innominate vein or the heart, and and then pericardial bleed, or intrapleural bleed, and then sudden death. Okay, so there are definitely advantages for transvenous, but definitely disadvantages, especially in pediatrics, because again, you put a lead and the patient's still growing, right? So, at some point the lead would get tight because the patient is growing. So it may get harsh.
They keep loops. They put loop
Right.
within the.
They put loop and stuff to compensate for this, but still, it's never perfect. Okay. So, so then subcutaneous though, it's just under the skin. So there's no risk of endocarditis. There is no risk of worry about extraction. And, infection is just, skin infection and usually relatively easy to deal with, okay, compared to, blood infection, okay, or heart infection, okay? So, and in this patient, he doesn't need pacing per se. Yes, he's a little bradycardic with beta blocker, but he's really asymptomatic. And, slowing of the heart rate in hypertroph is relatively good because it allows for filling and, less obstruction, okay? So I think this patient we are leaning towards implanting subcutaneous ICD on him because of, what we mentioned, okay? Any questions? So, we
what
do,
are
yes.
What
sorry.
are the complications of subcutaneous?
Yeah, the subcutaneous ICD
Infection?
Well, everything could get infected, but the infection is relatively superficial, and you can easily clear the infection with just opening the skin and stuff, okay, and taking it out. Like taking it out is way easier compared to transvenous. Okay, it's under the skin. Obviously, it's bigger. This can is way bigger, so patient, maybe a little bit of there's a little bit of more discomfort, or like it looks. I mean, it's usually under the armpit, so, or like a little bit below here, so it's less. It's hidden. But it's definitely bigger compared to the transvenous ICD.
How about the lead viability? Is it better than?
So the lead, the transvenous lead is very tough, meaning there is no reported fracture of a transvenous lead.
Transvenous or percutaneous?
Sorry, subcutaneous. I mean, there's no reported fracture, except just recently on Twitter, I saw a case where there was a fracture of a subcutaneous lead on Twitter, so it wasn't even published. But this is very rare. That's probably the first case. Okay. And do you see my screen, by the way? Can you see me, or no?
Yeah.
So that's the lead. It's very. This is the subcutaneous lead. It's very strong. Look, I'm trying to. Look, I cannot even break it. Look, I'm not very strong, but I'm strong enough, and it's not breaking. Okay. So it's very strong, okay? Okay, you see it? So that's it. So it's very, very strong. So there's no, again, there was no reported fracture except just recently on Twitter, which, I don't have much details, okay? And if I remember correctly, there was there was concerns about, the technique of implantation. Anyways, okay? So, but before implanting an ICD, you have to screen, screen the patient, meaning there are steps to do. You have to exercise the patient, and there's a programmer, like computer programmer, that you connect on the patient that tells you whether the ICD, if implanted, would be able to detect the QRSs, the T waves appropriately. So you have to do specific screening with exercise and resting ECG, and if the patient passes, then you're good to go. Okay.
So where it is attached? It's just subcutaneous.
Yeah, it's just under the skin. It's under the rib cage and then the sternum. When we do it, like we'll do it next month, I will call you. You'll see it. Okay. We will do it.
I attended a couple of cases at Gosh.
Yeah.
But all transvenous.
Yeah, it's more expensive. It's more expensive, and it's newer technology. Plus, it doesn't allow for pacing. So, if money is an issue, then people don't implant it. And if they need pacing, then they don't implant it. Otherwise, it should be better, especially for pediatrics. Again, this patient is going to survive for the next 80 years, And then if you imagine you implant transvenous today, every 10, 15 years, something happens, you have to do extraction, reimplantation. The veins would die off eventually, and then you're a little bit stuck, okay? Okay. Any questions?
Dr. Muhammad, 1 minute. Yeah, this case is intermittent pseudo.
No, not pseudo. This case, true WPW.
True.
True, yeah.
Where is the delta wave? Where is the delta wave?
Here, I'll show you. Wait, let me go back. I have to clean my, let me just go back. Well, there is short PR, right? Right, Ali?
Yes, sure, yes, yes.
Very
Clear,
short PR. And this is a Holter, this is a Holter, not, you know, an ECG. But, you know, there is a hint of a delta wave. And, you know, delta wave is not a must to diagnose WPW. You know, it's often seen. But you know, short PR and wide QRS is, you know, it could be also WPW. Okay, but there's a hint of, you know, there's a hint of delta wave, you know, at the, you know, at the you know, end of the P and beginning of the QRS. I have his ECG, and ECG it looks a little bit better in terms of delta wave, but this is, you know, something super short. You have to think of WPW. A PR is very short. You have to think of WPW. Okay, and then when it does this, you know. When it does this, when there is no you know, the PR changes on you like this, and the PR is always, when it's short, is always the same short, and when it's long, it's always the same long. Then you know there is, it's associated. You know, there's no, it's like Dr. Babu was saying, this is a slow VT at around the same rate as the sinus, but this is, you know, PR should not be always identical if this was the case. Okay, if they are, you know, if the VT is coming at the same time as the sinus rate, there must be some variation that the PR a little bit changes. In this case, the PR is always identical when there is WPW. Okay, so that's proof. You know, that, you know, that's proof that there is an association between the P and the QRS, and hence it's not VT. Okay, makes sense, Ali? A little bit.
Yeah.
Yeah. Okay. Okay. So long story short, I think this patient probably would deserve an ICD, and definitely if genetic testing came back with something, you know.
Mohammed, 1 minute. Why do you say definite indication? Because of the fibrosis and
yeah, fibrosis,
left atrial enlargement,
scarring, so much scarring on MRI. There is fibrosis. There's fibrosis. There is a thickening of the ventricle. And there's LA enlargement, which is not very, you know, for pediatrics, not very, you know, important. But the main two things that I'm worried about is the scarring and the LVH, the thickening of the septum, of the posterior wall. Okay, and the septum. Sorry, the septum. In this case, was the septum. Okay, and of course
more than 5 Z-score, right? You said
3 centimeters. Yes, yeah, so it's 3 centimeters. So it's more than 5. It's big.
More
it's
than
huge.
5. Yeah,
it's like
big,
a
huge.
It's huge. Yeah. Okay. Okay. So that's another example of intermittent WPW. You know, so it exists. We have actually many patients with intermittent WPW. So, you know, you see here P delta QRS, P delta QRS, and then P here loss of delta with not a QRS. Right? Everyone sees this. Okay.
Yeah.
You see, this is the pre-excited beat. This is non-pre-excited beat. Okay. So that's actually not that infrequent. Okay. You know, it's funny. We had, before COVID, we had ablation. You know, we had, I think, 5 back-to-back ablations in patients with intermittent WPW. It's, you know, it's usually not that frequent, but it does happen. Okay. Okay. So another example, right? Do you agree it's intermittent WPW? I mean, you know, non-pre-excited beat and then pre-excited beat. Okay. So Ali, you don't necessarily, like, for example, here, Ali, this is the delta wave. It's the downward, you know, downward deflection. Okay, it doesn't have to be textbook delta-looking wave.
Mohammed, this intermittent WPW also produce SVTs?
Yeah. Well, yes, because it could be. It's less likely, but could be, because Babu, remember, this is the, you know, this is the heart. Okay. Again. The accessory pathway may conduct intermittently from A to V, but all the time from V to A, right? So the pathway may conduct backward better than you know, forwards, okay?
Forward, okay.
Yeah. So in SVT, it may go down and up, down and up. So it doesn't, you know, doesn't care about antegrade conduction, okay? Everyone agrees that that's intermittent WW? Okay.
Yeah.
You see suddenly short PR and wide QRS. Okay. And
So let me ask you this question. Let me ask you this question. See, when you do stress testing, a sudden disappearance of pre-excitation is a good prognosis. So it doesn't correlate with this, huh?
It's a good prognosis. That's why when you have intermittent WW, it's the same idea. People initially the typical teaching is when you have intermittent WW or sudden loss of pre-excitation on an exercise test or a Holter, that's a good sign, meaning when you develop AFib, then the pathway is weak enough such that it will not conduct very rapidly into the ventricles, because when you are resting, it barely can conduct the atrial activity. So it doesn't make sense during AFib, it will conduct very rapidly, right? That's the logic behind it, right? Everyone gets this?
Okay.
Yes. However, this is not the case. This may not be the case all the time. And there are reports, and I'll show the data. There are reports of people with intermittent WW developing rapid atrial AFib with rapid ventricular conduction and VFib and arrest and dying. Okay.
Okay.
So it happens. It's less likely, but it still happens. And people don't understand why. Okay.
So maybe the presence of accessory pathway is a risk factor.
For him, you mean?
Yeah.
Yeah, maybe.
No.
Yeah. I mean, yeah, maybe. Well, I mean, there's no data, but maybe. Okay. Okay. So, the theme here today was intermittent WW. Okay. So that's another interesting patient, 4 years old. Okay. Has DCM with WW. Again, same story. Is this WW true or not true? Is it so that's the first question. Is this an accessory pathway that we have to worry about, or is it not? Okay, because remember, exact same thing, DCM and HCM with WW, it may be true WW or maybe pseudo WW. Okay, so that's his ECG. Can you answer this question based on what I just said, whether it's a worrisome WW, meaning it's true WW or pseudo WW? Can anyone tell me whether it's pseudo or true?
It is pseudo.
Why?
No, it is true. I will say it's true because there is some junctional. The
Okay.
QRS doesn't appear narrow with junction, so it is a true above the apical.
There is a delta wave, so it should be true.
Oh, no, well, in pseudo, there's also delta wave, Dr. Babu. Right?
Give it and you'll see.
Well, yeah, so sorry, someone had said
Junctional.
in junctional beat. So what do you noted? When do you note when the patient gets junctional beat? What do you note?
If it is pseudo, it will not change while it will be 10. While if it is a true, it will not change. It will keep widening.
No, if there's a junctional rhythm, you said that it can be pseudo.
Yeah, so it's the other way around. So again, so you are you are right that it's when you have junctional, okay, when you have junctional, the QRS would get narrow because you are below the AV node, below the accessory pathway. So here,
accessory pathway is below the AV node.
No. When you have true accessory pathway and you get a junctional beat, okay. So like here, when you have true accessory pathway and you have a junctional beat, the QRS would get narrow, right? Because you are going, downstream from the accessory pathway, right? So you get normal QRS, like in this case, you see this is a junctional beat, and it's a narrow normal QRS, right?
Yeah.
Right here.
If you have a true accessory pathway, it will get
narrow.
The junction will get wider.
No, you guys. Opposite, because here, that's the drawings again. Let me draw it.
Where are you drawing? I can't see your drawing. Yeah.
Okay, guys, everyone, here. You have an accessory pathway here, right? And you have a junctional beat that came here, right?
Yeah.
Right? So the QRS would be narrow because there's no pre-excitation. It will go down the AV node, his Purkinje system, narrow, normal QRS, right?
Yeah.
Right? So
Yeah.
you know, the delta wave is because this accessory pathway is going from the atria to the ventricle, you know, outside the his Purkinje system. So it's inefficient conduction. When you have AV node, junctional beat, everything goes down the his Purkinje system. You have a narrow, nice QRS, right? Yes, makes sense. Everyone?
Little bit.
Okay.
I got confused because you told us earlier,
Yeah.
if it shows junctional rhythm, accessory pathway is below the IV node. It's called pseudo WPW. That's what I thought you told us, isn't so?
No. I said if you have a junctional beat, and you have a true accessory pathway, the junctional beat would be narrow, normal. If you have a pseudo, because the pseudo is the accessory pathway is below here. So if you have a junctional beat, you'll get the exact same QRS because you're still going above, you're still going down the accessory pathway when you have pseudo, right? No?
I got confused.
Okay, let me draw this again. Okay, this red is clear, this drawing is clear, or you want different color?
Yeah, you can show us on this one. Yeah.
Okay.
Sorry, Dr. Muhammad.
Yes.
Regarding pseudo WPW, QRS will be normal duration?
Well, usually, so here, so just listen here. Okay, so you have sinus beat. Okay, you have true. Don't worry about pseudo now.
Are you drawing?
True. Okay, Babu, you see, there's an accessory pathway, right?
No, where are you drawing now? Okay,
yes,
okay.
Here. Okay, so this ECG would be P, short PR, delta, QRS, right? Right?
No, where are you drawing?
Here. You see me on the left side.
I can see.
On the left side.
Okay.
Yes. P, short PR, delta QRS, right?
Yeah.
Yes. Right. Okay, imagine the same patient has a beat coming from here, from the AV node, right? Would you see the delta or not?
No delta.
No delta, right? So you'll get narrow QRS with a T, right? Without delta, okay? Right?
Yeah.
Okay, so this patient, same thing. This patient has delta wave here, and with a junctional beat has a narrow QRS. So that's true WPW, right?
Yes.
Yes?
Yeah.
Makes sense, Babu?
Yes.
No. Why is it true?
Because you have junctional beat that is narrow.
And if it is pseudo, what happens?
If it's pseudo, so think about it. If it's pseudo, you know, pseudo here. So pseudo meaning you have an accessory pathway down below the AV node here, let's say, okay? Right?
Okay.
So you get junction beat, you'll still get widening of the QRS because still going down the accessory pathway. So you'll get, you know, the same QRS, it's wide dish.
No, I didn't get that. So here the
so you have to draw it. Just think of the electric, you know, imagine you're an electrical, you know, electron and you're going down the AV node because your junctional beat, and then you will meet the accessory pathway that's pseudo, that's below, right? You will meet it, right? So you'll get wide QRS, right?
No, I didn't get that. No. Okay, I'll ask you later.
Okay. Any guys, what about the rest?
I'm okay.
It's not clear.
I'm okay.
Yeah.
Because it is below because you have pseudo, it's down.
Yeah.
So it's gonna be wide either way. For
Why?
the true.
Yes.
For the true.
Yes.
It's gonna be the junctional should be normal.
Perfect.
Short.
Yes. Perfect. Yeah. Okay. Babu, just draw it. You will understand. Just try to draw it, and then you will understand. Okay. So this patient had, you know, has, you know, true WW, right? Right.
Yeah.
So you know, but it's intermittent. Again, it's intermittent because here there's a sinus beat here with loss of peak excitation, right? So this is a very interesting ECG. You have intermittent WW, you have junctional beat, and you know stuff, right? Okay. So this patient has DCM and has WPW. Okay. The question was whether you know, another question would be is this WPW causing the DCM or not, right? So because when you have WPW, it causes dysynchrony, right? Because you have pre-excitation. The ventricles are beating in a different, the conduction through the ventricles is abnormal because there's an accessory pathway. So there's dysynchrony because of the accessory pathway, right? So occasionally, very rarely, but occasionally when you have a patient with WPW, this patient may be at risk of decreased function and dilation of the ventricle because of the mere presence of the accessory pathway. Make sense?
Mm-hmm.
Yes? Makes sense, everyone? Yes, guys? No?
Yes, yes.
Okay.
Yes.
I am
Yeah,
lost.
this-
So.
Dr.
Okay.
Muhammad, in this ECG, QRS looks wide.
Yeah, there's WPW because of the WPW.
Ah.
So there's, we know there's WPW, right? Right, Dr. Ismail?
So it is true. So it is true, not so. Yes.
Yeah, it is true because the junctional beat is narrow, right?
Narrow.
Okay.
Junction beat. Okay.
Okay.
If function beat, how to differentiate between
So,
WPW?
So guys, forget about pseudo. I said it's an advanced. It's advanced. So if you don't want to worry about it, don't worry about it. Okay. So now focus on just accessory pathways. Okay. So
Yeah.
I can explain pseudo later. It's face to face. It's an important concept. You should you will get it. It's just draw it and you will get it. But let's we'll read it.
Mohammed, can you just tell us why the junctional beat will be broad if this pseudo?
Because the pseudo means the accessory pathway is inferior to the AV node, is downstream from the AV node. So you are starting from the AV node.
So why is it broad then?
Yeah, because it goes down the his Purkinje, but then eventually it gets into the accessory pathway, so it widens the conduction. It's not super normal. It's not very wide. Usually it's a little bit wide. Okay. It's not.
Okay.
It's like there is pre-excitation, distal pre-excitation. So it's a little bit wide, not so much. So that's why it's pseudo, meaning the PR would be usually longish, and the widening of the QRS usually is just minimal. Okay. And you will be nice. So we don't worry about it so much. Okay. Okay, so don't worry about pseudo, guys. So now this patient has true accessory pathway. The question is, occasionally, this accessory pathway may predispose the patient to DCM because there is dysynchrony of the ventricles because of the accessory pathway, right? Because in the accessory pathway, you have abnormal conduction down the ventricles, and then by definition, you have dysynchrony. You have abnormal, conduction, right? Mm-hmm. So rarely, patients with WPW may develop DCM. Okay, this is an important concept. Everyone gets that? Questions? Hello?
Yeah, I'm fine.
Yeah.
Clear.
Okay. So you have an accessory pathway that pre-excites the ventricle, and then you get dysynchrony. Usually the ventricles depolarize from the septum and apex and so forth. Here there's a difference in activation, so that's abnormal. Okay. So the question was to us whether this patient has DCM because of the WPW or because of because he has true DCM, genetic DCM, and has WPW in addition. Okay. So we did genetic testing. Long story short, he has mutation that is, that he has homozygous mutation. His mom and dad are like relatives, and they both have heterozygous mutation for DCM. So they were fine, but he has homozygous. So he got 2 bad genes, and he had developed severe DCM, and he has WPW as well, which was unrelated to his DCM. And we did ablation for him. It was, close to the AV node, but it has nothing to do with DCM. So, unfortunately, we were hopeful that the accessory pathway is the reason for DCM because that's reversible, right? When you ablate the pathway, hopefully the DCM would regress, right? But in this case, because he has genetic mutation, the DCM is unrelated to the accessory pathway. The accessory pathway may be a factor that worsening his phenotype or his manifestation of the gene mutation. But we don't think it's the case. We just think it's he has severe homozygous mutation explaining his severe DCM, and he probably would eventually need a pacemaker at some point. but he's completely asymptomatic otherwise, and he has on heart failure drugs. His EF is around 30-35%. Okay, so he's doing okay. Okay, but obviously he's at risk of SVT or arrhythmias, and when he does this, he may not tolerate it because of DCM. Okay, okay, so that's his AV node. This is the yellow dots were his AV node, and the green dot was where the ablation was successful. But like mechanical, there, when the catheter went here, the accessory pathway went away, but then we burned a little bit behind that to avoid AV block, because he had intermittent AV block when we burned here. So we did minimal ablation, not on the exact spot, because in the exact spot it was adjacent to the AV node, and he was having AV block intermittently. So anyways, so just last, I think this is the last, just last 2 slides, okay? So again, that's another ECG. It's normal ECG, but you have to pay attention, and there's one pre-excited beat here in the middle. So that's why you have to see all ECGs, okay? Again, intermittent ECG, WPW in a patient with only 1 beat of WPW. So, often this many people would miss this ECG, would call it normal, but there's in fact intermittent WPW, right? Okay. 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 Let me. So just one last point. So in terms of loss of pre-excitation, intermittent WPW, like we said, this is like you just published, huh? Like this is just last week. It's very new paper. This patient, if you see this ECG, he has WPW. There's a little bit of delta wave, short PR, right here, nice delta wave, right? You see it?
Yeah.
Okay.
Yeah.
And then another ECG without WPW, without short PR and delta wave. So by definition, he had intermittent WPW, and then he did this one day. Okay.
Oh,
exact same thing.
Torsad, huh?
Torsad. Okay. So it does happen. Less likely, but it still happens. Okay. So okay. So I think I will stop here, because we are we do have we will we're out of time. But I don't any questions, we have lives, please ask. If you don't understand anything, you can ask me now. We can repeat things, but the take home message is that there are risk factors for HCM that are not super duper clear in pediatrics in order to determine which patient needs an ICD. So you have to speak with the family, do MRI, do genetics, do Holter, do stress test, do echoes, good family history, good personal history, so forth. So you have to collect so much data, and then only then decide whether he needs an ICD. Don't be super aggressive, because you will implant the ICD prematurely, and then you'll have the complication of the ICD that you don't want, right? Unfortunately, drugs per se are not protective from sudden cardiac death in hypertrophic cardiomyopathy patients, okay? So you cannot rely on drugs per se. If someone is having symptoms, drugs may help, but drugs would not prevent sudden cardiac death. It's not proven for that drugs prevent sudden cardiac death in hypertrophy. Like in long QT, it's a different story, but in hypertrophy, it's not. So first of all, your first question is whether this patient needs an ICD, and then what type of ICD? Does he need pacing? He doesn't. Is it transvenous? Is it epicardial? Is it subcutaneous? And then go forth. And we talked about intermittent WPW and how to diagnose it, and what does it mean. And then we touched on pseudo WPW, but I'll ignore this. It caused a little bit of confusion. So just ignore pseudo WPW. Just know that it exists. It's good to know that it exists. But electrophysiology will determine it. However, know that intermittent WPW may be a good sign, but not all the time. And know that if you have a junctional beat that is narrow, it proves presence of a true accessory pathway. Okay. Any
Mohammed, one question regarding WPW in normal patients, like not direct cardiomyopathy, do you start treatment, or I know you're gonna send them for electrophysiology when they reach 25 kg or less, depending on the protocol of your center.
Yeah.
But for small babies, like if we have a neonate with WPW and he's totally asymptomatic,
Yeah.
so usually I follow them up. I don't start treatment unless they have symptoms or unless they have one event.
So good question. So, you know, what we usually do is, you know, if they have an SVT, of course you treat. If they are asymptomatic, you don't treat unless they have symptoms or, you know, they develop SVT. You know, meaning, so usually SVT happens more so when the baby is in utero or when he's, you know, during the initial 4 to 6 months of age. And then it quiets down because there is probably less PACs that happens after, you know, the myocardium is matured. So usually between 6 months of age to 6 years of age or 7 years of age, things are super duper quiet, okay? So between 6 months or 8 months and 6 years, I don't do anything, just monitor. But I don't tell them go home, I don't come back. I tell them come back every 6 months or 1 year, okay? As long as there's WPW. So you do drugs if there is SVT. If there is no SVT, you monitor them. When they are like 6, 7, 8 years of age, meaning when they are like 18 kilos and above, you offer ablation, okay? So that's the, you know, what we typically do.
Smallest ablation that usually done.
Well,
this.
If you have to do ablation, there are reports of ablation done in newborns, okay? So if you have to do ablation, you can do it at any age. But of course, you know, if you can do only if drugs are successful and controlling things, obviously better to wait until 18 kilos and above. Okay. 15 to, you know, some people say 15, some people say 18 and above. Okay.
Okay, Mohammed, one question.
Yeah.
Because I got confused now. Now, this, when you say pseudo WPW, there's no accessory pathway. That's what you are meaning?
Well, there's no accessory pathway that carries a risk for developing VFib, you know, because let's say this patient gets AFib, it will still go down the AV node before it reaches the accessory pathway. So then it's a almost meaningless accessory path, meaning it's just there, it doesn't do anything. Okay. Rarely it causes trouble, but this is very, very, very unusual. So I wouldn't worry about it. In general, I wouldn't worry.
So in pseudo WPW, it is usually the pathways connecting below the AV node.
Right. So that's why it's good. It's not a high risk pathway because AV node protects from rapid conduction. Okay.
Okay.
You know, the significance of pseudo WPW, oftentimes it confuses people, meaning people may go to the EP lab because of the pseudo WPW, and then you risk, you know, you do an invasive procedure for a patient with a benign accessory pathway. So that's why you have to be aware of it. And if you think it is, or if you're worried about it or not worried, if you are suspecting it, you'd give adenosine challenge test. You do other things to prove that it's not pseudo before doing an invasive procedure for the patient. Okay. So that's the.
Do you control them in beta blocker, or you don't control them?
No, they are usually
benign.
Many things. Yeah, usually benign. Usually.
Benign.
Yeah, there are reports of, you know, something, you know, VTs from them, but this is very, very unusual. So I've never seen it's very unusual. Okay. So, so in general, the take-home messages, you know, if you do adenosine challenge test and it's the QRS did not widen, there's AV block without widening of the QRS, that's you know, that's a good sign. And you know, that delta wave is not true or is pseudo. Okay. And oh, by the way, and you know, if you for some reason, babies with hypoplastic left heart syndrome, this is, you know, pediatrics, very often they would have delta-looking QRSs, you know, initial QRS, and you know, it's not true WPW, it's just pseudo WPW. So if you pay attention to, especially hypoplastic, you will see many of them, they do have a pseudo or WPW pattern on ECG, but it's not WPW. So that's why, you know, you have to be aware of this and then don't react to it because it's probably pseudo. Okay. So when you have myopathy, often you have an ECG that looks like WPW, but it's not WPW. Okay. Okay. That's why it's important to know about. Okay. That's why you have to know about it and, you know,
Thank
think
you,
about
Mohammed.
being aggressive. Okay. Question.
One question, Dr. Mohammed, please.
Yes. Yes.
In subcutaneous ICD, why not connected to epicardial lead like BBI and get the benefit of bracing and saving battery also?
Yeah, well, it's less surgery, you know, like if you want to, it's open chest.
Thank you.
Bye. It's open chest versus, you know, versus subcutaneous, you know. So, you know, this could be done under, you know, some people do it under not like aggressive local or like, you know, nerve block.
Nerve block, yeah.
Yeah. So you know, adults, they do it under some of them, not all of them. They do nerve block and, you know, not intubation even. So of course, you know, less risk of surgery, you know, in the epicardial open chest and, you know, and if the patient had, let's say, heart surgery before, there's so much adhesion, there's so much risk of, you know, bleeding and you know, and surgery. So this is way less benign, way less, invasive, more benign.
Thank you.
Okay. The only disadvantage of it, it's not, doesn't pace, plus it's very big. So you cannot do it on a baby.
Painful, very painful also.
Very painful, it's big. And, you know, it needs to, at least, you know, the recommendation is the patient should be at least 45 kilos. So, you know, nowadays, most of our 11 years old, 12 years old are 45 kilos because, you know, obesity. So, but in general, you need to be at least 10, 12, 13 kilos and, 8 years and above to have this implanted. Okay.
Okay, so there is more incidence of fibrosis, like the senile pacing and maybe frequent shocking.
Fibrosis, you mean where?
At the site of giving. After that, you will lose the benefit for this.
Well, yeah. So there is, you know, pocket fibrosis. You know, sometimes there is enhanced pocket fibrosis that such that the shock would not be effective. There are reports of this. You're right, but you know, it's just reports. So it's not, you know, it's not a must. It doesn't happen all the time. It happens sometimes. That's why sometimes you test it. You know, sometimes people, when they do generator change, they sedate the patient, they induce VFib, and they test the device. And if it works, then they know there is, you know, it's good to go. If it fails, then, you know, you have to place it somewhere else. You have to remove the fibrosis or do a transvenous implant instead. But remember, the surgery in it is all subcutaneous surgery. So it's besides scarring, it's not super big deal. You know, there's so much scarring and pain and stuff, but it's not, you know, there's no risk of, you know, death or perforation or, you know, so there's, you know, there's so much, you know, there's so much skin surgery, but it's only skin and, you know, under subcutaneous surgery. So, and it's done, you know, by, you don't need a surgeon to do this and stuff. So, okay.
Okay,
so
thank
it's
you.
a good, you know, it's a good device. It's new technology, good device. There are obviously, there's nothing that without, you know, side effects, but, you know, it's promising and I like it. And especially for hypertrophy, it's a good device. Okay. If it passes the screening test. Okay. Okay. Any other questions?
Thank you, Mohammed. Thank you.
Okay. Thank you. Bye.
Bye-bye.
Thank you, Mohammed.
Thank you. Bye.
Thank you.